So in today's class, we are going to move forward with the GIT. I understand that right now we are just speaking anatomy, and anatomy is no fun, but still, we can understand a few topics from it. For example, I want to get you comfortable, guys, with a little bit of CTs. So let's do a few pictures of CT together, and just to try to identify the organs together. So, okay. So can someone tell me, please, what is this organ? Liver. What about this? This. Gallbladder. What about this? Kidney. What about this? Spleen. What about this? Kidney. What about this? Okay, what about this? Inferior vena cava. Yeah. Okay, what about this? The pancreas. Good. So I just wanted to make sure you are guys oriented, you know what you are looking at, and because they literally put you an arrow and ask you what is that. So one more question. Does anybody know what is this? This thing. Well, this is a muscle. It's called the psoas muscle, which is this one. Super important to know. They love it in the USMLE. I truly don't know why, but they really like it. Basically, it's the same as this muscle. The psoas muscle, it connects your vertebrae to your psoas muscle, to your lower extremity. As you can see, this is the psoas muscle. And it's really important for the ability of extension of your lower extremity. So let me send you this. Okay. And the next thing I want you to know that the ascending and the descending colon are retroperitoneal organ. So that means they are easier or more difficult to operate on. Much more difficult to operate on. Absolutely. Okay, so we spoke about the ligaments the other day, and now we are going to speak a little bit of histology. It doesn't matter which portion of the GIT we are speaking about. All portions have the similar layer. These layers include the following. We have MS. So we have the mucosa, which consists from the epithelium and the lamina propria and the muscularis mucosa. The first question that you should be able to answer: which type of epithelium is inside of the GIT? Well, it's mostly columnar. Some portion have it squamous. Well, actually it depends. If we speak about the esophagus, it will be stratified squamous. If we speak about the stomach, it will be columnar. If we speak about the small intestine and the large intestine, it's columnar. Well, if you would like to know all of the other types of epithelium that we have inside of our body, refer please to the a PDF file that I made for you guys like a month ago. It's called Circulatory. You can find it, and it has all types of epithelium that you need to know for the USMLE step 1. And the next one is about, so that's the mucosa. So what about the submucosa? The submucosa has submucosal nerve, the mesenteric nerve, which secretes fluid. Okay, so the mesenteric plexus is responsible for the secretion SS secretion. Well, what does the GI epithelium secrete? An idea? Or submucosa secrete? Yep, some of it secrete acid in the stomach, some of it secrete bicarb in the duodenum, some of it secrete mucus in the goblet cells. And yeah, the muscularis externa, this is important. It has inside of it something called mesenteric nerve plexus, also known as the Auerbach, which is responsible for the motility. For the motility of the GI tract, after all, guys, you are doctors. You need to understand how the motility goes. Why? That will be important for that, yes. So, motility of the GIT, or peristalsis, we call it. The movement of the GIT, we call it peristalsis. Okay, so we have two layers of muscles inside of our GIT. If we are speaking about the muscularis. The muscularis has two portions. They are not showing it here, but I hope they do. Oh, yeah. So, they are showing it here. So we have a circular layer and we have a longitudinal layer. So I want you to imagine that this is the intestine, and I'm going to make two layers. So this is the intestine, and we are just speaking about the muscle, of course. So let's make the first layer of intestine. It will be like this, and this is the longitudinal layer, yeah? And the other layer is going to be the circular layer, yeah? So it goes like this. Now you will understand why this is important, guys. So if we speak about the circular layer, when the peristalsis occur, what happens? It just do like this. So what is happening to the food inside of it when it's doing this? It gets crushed. The most important thing that it gets crushed. Okay, so the next one is this one. It moves like this also. So what will happen with the food when it moves? This is the longitudinal one. When it moves, it's going to move the food forward because it will be more difficult for the food to move, so it will move forward. I hope you can understand it. Basically, when this moves, the food will get squished forward and it will go to the right. Basically, if we have food coming from here and you are squishing it, the food is forced to go to the right, yeah? Yes, so this is how this layer works. But if we speak about the circular one, its main function is just to crush the food, okay? Okay, that's why when they tell you, oh, the patient have constipation because overspasm. I hope you understand what that means now. So if the patient has a spasm, really bad spasm of his muscles, that means that this is constricted, and this is constricted. Yeah? Also, this is constricted and this is constricted. Can the food move if we have such a situation? Absolutely not. So that will lead to constipation. Constipation, that's the idea. So if you have overstimulation of your GI tract, you might also get constipation, not diarrhea as you might think. Okay, so the serosa, which is the last layer, but be careful, serosa only in intraperitoneal organ. If the organ was retroperitoneal, we call it adventitia. So if I'm telling you stomach, is the stomach having a serosa or an adventitia? Stomach. Stomach has a, it's enough to write the first letter. Serosa. Serosa. Absolutely. If I'm telling you about the duodenum, the second portion of the duodenum, remember, guys, when we speak about the stomach, this is the stomach, and the duodenum is like this. So until here, until the first portion of the duodenum, all of this will be covered with serosa because all of this is intraperitoneum. But the second second, third, and fourth portion of the duodenum are retroperitoneal organ. That means they will be covered with what? Adventitia. Absolutely. Okay, good. We can move forward. Ulcers can extend into the submucosa, inner or outer muscularis layer, while erosions can extend only to the mucosa. Let me explain. In the clinic, you might hear the word, oh, that person has an ulcer, that person has an erosion, that person has an gastritis. You must be comfortable to understand what is the difference between these. Someone with just a gastritis, he had just a superficial inflammation, no actual damage. But somebody with erosion, that means this layer, see, we have the mucosa, as you can see, it has epithelium, lamina propria, and muscularis mucosa. All of these are scratched off, okay? That's named erosion. So if you scratch all of these minor layer in the mucosa, we call it erosion. Okay, let's say that it keeps going. If you cut the submucosa as well, how do we call it? It becomes an ulcer. So the difference between the ulcer and the erosion is involvement of the submucosa. This question is going to be on the MCQ later today. So the difference between the difference between erosion and ulcer is the involvement of what? Involvement of what? The submucosa. Done. Okay, good. So the next point is about the frequency of basal electrical rhythm, the slow waves, which originate in the interstitial cells of Kagel. So let me explain about this. So there is something called peristalsis frequency and how fast it goes from one organ to another organ. You should know that if we are speaking about our duodenum, the speed of it is totally different from the speed of the stomach, which is totally different from the speed of the GIT. Now comes the question, should I know about the speed for each organ? The answer is not. You should not. Notice here, when we are speaking about the contraction, it happens in peristaltic movement. So, crush, 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 relax. Crush, 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 relax. Crush, 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 relax. So that's how the GIT peristalsis act. Okay, finally I found it. So yeah, the stomach only moves 3 times per minute, the colon is 9 per minute, and the jejunum is 15 per minute. Well, now comes the question. Why the hell the jejunum is the faster? Why the jejunum is faster than the colon, and why the colon is faster than the stomach? Anybody know? Just have a wow. Okay, I did not expect someone to know that. The length. So each of these work in a way that it will kick out the food the fastest it can. So if we speak about the jejunum, he's really long. So it needs to have much more contraction to propagate the food or whatever it has in it forward. The colon is shorter, so it needs less contractions, and the stomach is the shortest, so it needs the least contractions. Before I move forward, I need to go back and tell you guys about 2 things that you must get from this concept. First of all, the submucosa and the muscularis externa. The submucosa, SSS, secretes, and it has the mycelial plexus. And if we speak about the muscularis serosa, myenteric plexus for motility. Okay? These you need to master. If we speak about an ulcer versus an erosion, you need to know that erosion is mucosa only. An ulcer involves the submucosa. Digestive tract histology. Guys, they show you a histology of the stomach. And they give you an arrow in one cell and they ask you what is that. I mean, seriously, how the hell are you able to diagnose, to know that? I mean, you are not pathologist after all. Well, there is a way. And there is a trick. There is always a trick. So let me teach you how to deal with their tricks. So in the future, when they show you a cell like this, you know that this is a chief cell and this is a parietal cell. So let's learn how to do this. Okay, I will use this one. So if we start with the esophagus, it has a non-keratinized stratified squamous epithelium. And keep in mind that if we are speaking about our outside skin, it has keratinized stratified squamous epithelium. Guys, why we like to use a stratified squamous epithelium in the esophagus? Why? I mean, why we don't have it in our stomach, for example? Why only the esophagus and the mouth has that, and the lips actually? Well, to be totally fair with you, it's because of its ability to overcome trauma, okay? Wow, okay. So, to overcome trauma. So, if you have 16 layers of epithelium and you eat that burger, yeah, like burn, for example, or you eat that really hot soup, okay? Or you eat that dish with a lot of grains in it, okay? And they come down and they take 2 layers from your squamous epithelium. Are you going to have perforation, or you have just more layers and no problem? You have no problem because you have still so many other layers. So that's why we have it in our esophagus. On our skin is the same deal. So the esophagus is divided into 2 portions. We have the upper 1/3, which has striated muscles. What do I mean by striated muscle? Skeletal muscle, yes? And the middle and the lower 2/3 have smooth muscles, okay? With some overlap at the transitional point. So if we speak about the esophagus, it's like this. The first 1/3 has skeletal muscle or striated muscle. The last 2/3 are smooth muscles, okay? So when we speak about the stomach, it has gastric gland, and this gastric gland are seen here. So they tell you that they contain parietal cells and they contain chief cells. How I'm going to differentiate parietal from chief? Well, the answer is it's actually quite easy. The parietal cells, guys, parietal cells start with a P, so it's pink. While chief cells is basophilic, okay? Remember, the chef in the basement. So basophilic. So let's take a look. Can somebody tell me, is this cell a chief cell or a parietal cell? Just write the first letter. Okay, guys. It's a parietal cell. Why? Because it's pink. It's pink. We don't look at the nucleus. The nucleus always will have the same color. We are looking at the cytoplasm. So let's try this again. If we are speaking about this cell, this one is a chief cell. Okay, I see the confusion there. So let me try a totally different picture from here. Okay, nice. Can you see the cell? What do you think it is? Pink, so parietal. What about this cell? Chief cells, because it's purple or blue. So let me do this. Okay, so I can tell you like this. This is parietal. Why? Because pink, and you just keep going. And if you see something like this, it's blue, so you go basophilic, which is chief cells. Yeah, that's it. Okay, you're like, well, fine, but still, I am not a master in this stuff. I can totally like make a mistake about this. If you show me a histology, it's kind of like, not that easy. So I agree. I totally agree. So we will try to make it a little bit easier. Let's see how can I make it a little bit easier. So the way to make it a little bit easier actually is to look at this. Notice, you can see the chief cells and the parietal cells. Which one is located lower? The chief cells. He's in the basement. Remember when I told you the chief cells in the basement, basophilic? Yeah? So the chef in the basement. So next time they show you a picture like let's see. Yes. They take a picture from here. And they just give you some random arrow that is pointing downward. What you will choose? Chief cells, absolutely. If the arrow was pointing upward at the pinkish area, parietal cells. That's it. Not that difficult. Okay. So the next point is, oh yeah, so you can see here's much better picture. Chief cells are bluish, parietal cells are pink. Let me send you this. Done. Good. Please be comfortable how to differentiate between parietal cells and chief cells. All the time they keep getting questions about this. So the duodenum, villi and microvilli increase the absorptive surface. So when you have villi and microvilli, that means I have increase in the surface area. So it's really good for the absorptive function. So think about it logically. If it's really good for the absorptive function, should I have it in my esophagus or in my small intestine? Small intestine, absolutely. So they have villi and microvilli that increase the absorptive surface. We have something called the Brunner glands, which secrete bicarb, okay? From the submucosa. Why submucosa? Because we said the submucosa is responsible for the secretion, yeah? And it was controlled by the Messinian plexus. And we have the crypts of Libercon. Guys, know about the crypts? If they ask you where is the stem cells of the GIT are located, you need to say the crypts. If they ask you where is the stem cells of the skin located, you need to say striatum basale. If they ask you where is the stem cells of the lung, you need to say alveolocyte type 2. Okay? If they ask you about the stem cells of the brain, you need to write for them microglial cells. If they ask you about the stem cells, what else? What did I did not speak about? Of the blood is the hematopoietic stem cells with the CD34 plus. Okay? So they contain the stem cells that replace the enterocyte and the goblet cells and even the Baneth cells. The Baneth cells normally secrete defensin and lysozyme and TNF. These are an innate immune system protection, yeah, which prevent the bacteria from infecting us. The jejunum also has a villi and the crypts of these crypts as well. And this is important. It has a Blesia circularis, which is present also in the distal ileum. Let me explain what is this Blesia circularis and let me show you how they ask it. Blesia circularis. So when we speak about the Blesia circularis, it's this ferro. Can you see how it looks like? We have so many bends in it. So it does not exist. What you have to know that it does not exist where? It does not exist in the ileum. Because it does not exist in the ileum, this is highly important. Why? Because by a simple picture, you can differentiate on the barium study what is the ileum and what is the jejunum. Yes? So, guys, I will show you this picture. This is a barium study in which we make the patient to drink some solution that is radioactive and we can take a look what everything is located. So I'm going to give two arrows. This is arrow number one, and this is arrow number 2. Which one is the jejunum? Which one is the ileum? One is jejunum, yeah? Okay? Yes. Why did you say that? No ferrous. And the ferrous were because of the Blitzia circularis. So, from just a standard picture of barium study, you can differentiate the jejunum from the ileum. Good. Does anybody know what that is? Nice. What about this? Duodenum. Notice the most distal portion of the duodenum also has ferrous. Okay, nice. Good, good, good. I'm really happy that you were able to recognize it right away, because normally it takes a lot of time for people to get it. So that's good. It's a good sign. Okay. The next one is the ileum. It has a villi and Beer's patches, which is basically a lymphoid tissue. Lymphoid aggregate, which are located in lamina propria and the submucosa. A Blasia circularis only in the proximal ileum, because the Blasia circularis actually is not for the ileum, it is for the jejunum. And they also have the crypts, and they have the largest amount of goblet cells in the small intestine. Keep in mind that the function of goblet cells is to secrete mucus, okay, which can facilitate the movement. The colon has crypts and that are abundant with goblet cells, but has no villi, because the main function of the colon is to suck the water, not to suck the food. Yes, it actually tries to suck the water out of the intestine and reduce it as much as possible. Okay, let me show you an ileum histology. Okie dokie. Oh, nice. Okay, I like this one. Can somebody please tell me what is this? Oh, sorry. What is this? We have one here, we have one here, we have one here. No, this is not the crypts. The crypts are here. See? If you go down like this, this is the crypt. This is the Bayer's batches, guys. Bayer batches, okay? This is the Bayer's batches, which make you, it's the lymphoid tissue. So basically this is the germinal center, okay? It's a picture of the ileum with the Bayer's batches, which have the germinal center is white tissue from the inside. So what do you think? Is it active or inactive if it is white tissue from the middle? A white is active, absolutely. So if we speak about the germinal center, does anybody know which antibody will be produced and secreted on the surface of the ileum? IgA, nice. Okay, IgA. The IgA to be secreted, remember, it needs this secretory proteins to come with it, okay? So one more thing, the jejunum, you can see it here, but what I want you to see actually, yes, okay. What is this little whitish area here? You can see like little whitish area. What are these? In the mucosa, submucosa, sorry. You can even notice them here in the jejunum. Like if you take a look here, you can see one is here, one. What are these? Goblet cells, absolutely, which secrete mucus, yeah? Goblet cells. The crypts are here, guys. This is the crypt, okay? This is the crypt. This is the crypt. This is the crypt, okay? The crypt is the lowest portion inside of the crypt. So it contains the stem cell of the GIT. Well, just I'm throwing a dart in the arrow. Does anybody know inside of the crypt which stage of the cell cycle it is? It's a stem cell, so it must be in which stage of the cell cycle? Absolutely, stem cells, so it must be in the G1 constantly. It cannot enter the G0. Yes. Good. More anatomy, abdominal aorta and its branches. I want you to notice something before I say anything. The aorta is always on the left of the patient and the inferior vena cava on the right of the patient. For the sake of our future conversation, I want you to know what is a normal anatomical position, okay? So the anatomical position looks something like this. It is a man standing with his palms facing forward. You must know this. So his palms are facing forward. Okay, so this is the normal anatomical position that you need to know for medicine. And if you take a look at this patient, of course, this is the left of the patient and this is the right of the patient. All of the blood supplies that supplies the GI tract goes anteriorly. All of the blood supplies that supplies anything else comes out laterally. Again, let me repeat this point. It's important. All of the blood supplies that gets out and supplies the GI tract gets out anteriorly, like the celiac trunk, the SMA, and the IMA. All of the branches from the aorta that supplies anything that is not an intestine comes out laterally, like the inferior phrenic, which supplies the diaphragm, superior suprarenal, middle suprarenal, inferior suprarenal, renal, gonadal. None of these are the intestine, okay? I hope it makes sense. So all of the anterior one are GIT, all of the other ones are not GIT. So arteries supplying the GI structure are singular and branches anteriorly, as you can see. Arteries supplying non-GI structure are paired, which means one to the right, one to the left. And they come laterally and go posteriorly. Okay, so two areas of the colon have a dual blood supply from arterial branches. Well, is that a good thing or a bad thing to have a dual blood supply? Well, it's actually a really bad thing, but let me explain for you why. I hope you remember what is a watershed area. Basically, if we have a tissue like this, and we have this is the first blood supply, okay? Okay. And there is some other organ. So let's say this is the superior mesenteric artery, okay? And it's supplying this like the splenic flexure, okay? But if you, yes, but that's not the problem. So the splenic flexure is here. And the next area, I will make it in a different color, black. And this is supplied from the inferior mesenteric artery, okay? So this is inferior mesenteric. Okay, I suck at the drawing, but basically it's like this, okay? So you are like, well, if I block this, if I block the, so this is inferior mesenteric artery. If you block the superior mesenteric artery, the blood will keep flowing from the inferior mesenteric artery and the patient will be healthy. If you block the inferior mesenteric artery, the blood will come from the superior mesenteric artery and you will be healthy. So this situation actually sounds like a good situation, not a bad, except in case of shock. If you have shock, what is going to happen to the blood flow to the SMA? More or less? Less. What about to the IMA? Also less. So what is going to happen to the area in between? This one. Ischemia. Absolutely. That's watershed area. So in cases of shock, you will have less blood supply from the dual sublimement, if I can say, from the two arteries, which will lead to watershed area. I know my drawing sucks, but here you go, guys. Enjoy. So the next thing is about, it's more susceptible to colonic ischemia. I hope it makes sense. So we have two of these actually. The first one is the splenic flexure. I just explained that. It's between the SMA and the IMA. And the next one is the rectosigmoid junction, which is the last the last sigmoid arterial branch from the IMA, and the superior rectalis artery, which comes from a totally different origin. Now, before I move forward, I want somebody to tell me, in case of horseshoe kidney, the kidney was stuck under which vessel? Inferior mesenteric artery, absolutely. It was stuck under this guy. The kidney was like this, and she was stuck like here. Okay, because kidney comes from the pelvis and go upward, yes? Okay, so we have something called the nutcracker syndrome. Let's speak about it. So the nutcracker syndrome, it's a compression of the left renal vein between the superior mesenteric artery, this guy, and the aorta. So exactly right here. So let's try to understand why such a thing might occur. So we have the superior mesenteric artery, okay, and we have the aorta. And as you can see here, we have the left renal vein going through here. And we have what else? We have also the duodenum. So the duodenum is going literally under here. Yeah? So there is something that can happen that will decrease the amount of material located here, which will lead to the compression of the SMA against the duodenum. What do you think this thing is? What can lead to that? Well, actually, let me see. Not really. It's basically the vessel is like this, okay? The duodenum is like this. Basically the left renal vein is like this, and there is a lot of fat in between, okay? There is a lot of fat in between. And let's say that you lose a lot of fat. You lost it. So when you lose the fat, this is going to compress this, which can lead to one of two problems. It's either going to give you superior mesenteric artery syndrome, or it's going to give you nutcracker syndrome. Both of them are bad. So basically it's because of weight loss. So it may cause abdominal or flank pain and gross hematuria from rupture of a thin-walled renal varicosities. Left renal varicocele. Let's try to understand why we have a left renal varicocele. I hope you remember, where does the left gonadal vein drain to? Does anybody remember where does the left gonadal vein drains to? Where does the left gonadal? Yes, absolutely correct. So as you can see, this is the gonadal vein, and this is draining to the left renal vein. So let's imagine that this gets compressed. I mean, because of this. Let me do this to make it make more sense. Sending you this picture, then I'm going to put it here, and I'm then going to alter it a little bit. So, of course, we have the aorta going here, yes, and actually it's like this, posterior to this vessel, and then coming back here, and posterior to this vessel, and then coming like this. Yeah. So keep in mind that from the aorta we have the superior mesenteric coming like this, and there is fat here. So if you lose the fat, what is going to happen to the superior mesenteric? Compress. If this is compressed, what is going to happen to the pressure inside of the gonadal vein? What is going to happen to the pressure inside of the gonadal vein? It will be high. So that will lead to increase pressure in what is this? What is this? The warm bag, also called bambiniform complex, and plexus, and that will lead basically to a varicocele. Yes? Okay. So if you palpate it, it's like a bag of worm, and if you try to put a light on it, will it transluminate? Yes or no? Will it transluminate? No, it will not. What about the hydrocele? Will it transluminate? Yep. So superior mesenteric artery syndrome characterized by an intermittent intestinal obstruction. So symptoms primarily postprandial pain. Postprandial, what does it mean? Postprandial means yep, after food. Again, the same story. You lose a lot of fat, you have compression of two vessels, of two things. First of all, this is the left renal vein, and this is the duodenum. So both of these will get compressed. You can get either nutcracker, or you can get nutcracker and then after some time develop the superior mesenteric artery syndrome. In this syndrome, you will have an intestinal obstruction. Why? Because the SMA is compressing it. So they write when the SMA and the aorta compress the third portion of the duodenum, and sadly you have to know that it is a third portion of the duodenum, also known as the transverse portion. Let me explain. The duodenum has the following portion. So when it comes from the stomach, it has the first portion, and then it has the descending portion, and then it has the transverse portion, and then it has the ascending portion. Okay, so the third portion will be the one affected. It typically occurs in conditions associated with diminished mesenteric fat like low body weight or malnutrition. So the patient is going to eat, the food is going to come here, but it cannot pass forward. That will lead to colicky pain. Colicky pain means it's a type of pain that comes and go. Guys, the next thing I want to speak with you about is something called femoral artery. It's not mentioned here, but just for the sake of completeness. So femoral artery is, yes. Okay, so you can see the femoral artery, it's basically a branch of the external iliac, yeah? And we utilize it in case of catheterization, okay? So when you wanna open up a vessel inside of the heart, you can go through here and keep it going. Why I'm telling you this? Well, because it's important, that's one thing. And the second thing is that sometimes accidentally you might damage it. If you damage it, you will have blood. And if the blood was going to exit from here, where it's going to go to, guys? Not a gun. No, catheterization. It's catheterization. It's like a needle. You put the needle and you open it up. I mean the artery, and you keep going backward until you catheterize the heart. Okay. After you open up the vessel, you draw it back. But sometimes you can accidentally lead to hemorrhage here. Yes, you can accidentally burst the vein. If you burst the vein, there will be bleeding. But where the bleeding is going to be? Well, basically, what happens that if you burst that vessel, yep, take a look here. This is a common USMLE question. Yes, so take a look here. If you put it here, look, how do we actually put it in? We palpate the inguinal ligament, we feel the artery, we burst it and go inside. This is my future specialty, so I really care about this. So we form a hole here, and from this hole, we will have a humongous bleeding that will go to the back. Obviously, gravity, guys. The patient is laying on his back, so all of the blood will go to the back, to the retroperitoneal space, okay? So if they mention you a patient with catheterization that comes back to you 4 hours later with a hemorrhagic shock, and they ask you which compartment has the blood, put an answer, retroperitoneal space, okay? Okay, good. So one more concept before the break. Let's speak about the gastrointestinal blood supply and innervation. So we have foregut, midgut, and hindgut, all of them coming from the endoderm, yes? So if we speak about the foregut, it starts from where, guys? Can somebody tell me where does the foregut starts? Yep, starts from the esophagus downward. Some books write the oral cavity, but I noticed that in the USMLE they like to say the esophagus. So the esophagus, and yeah, all of this structure will be supplied with the celiac one way or another. We'll speak about the exact blood supply after the break, but the parasympathetic innervation comes from vagus, the same from the midgut. But for the hindgut, they come from the pelvis. Make a note, S2 until S4, okay? I mean from the spinal cord segments. So if they ask you which segments they are, it's S2 to S4. So this is from celiac, midgut from the SMA, hindgut from the IMA. When we speak about vertebral level, I mean, about the vertebral level, it will be T12 to L1 regarding the innervation, of course. And the structure supplied will be the following. For pharynx, it's only the vagus. For lower esophagus, it can be celiac artery only until you reach the proximal duodenum, in which there we are going to shift to the what? We are going to shift to where it is, to the SMA. Yes? When we speak about the distal duodenum, after the 1/4, we can say that we have an SMA blood supply. All of the other organs inside of our intestine, until like that portion of the duodenum, are going to be supplied by the celiac. By the way, guys, the only organ that is supplied by an endodermal blood supply, but he is a mesoderm, that will be which organ? The spleen. Let me repeat the question because they do ask it. The only organ that is a mesoderm but supplied by an endodermal blood supply is the spleen. Okay? So the next one is the midgut, supplied by the SMA and vagus. It's associated with L1 innervation. Distal duodenal to proximal 2/3 of the transverse colon. The splenic fracture is considered as a watershed area. The hindgut, the distal 1/3 of the transverse colon until the upper portion of the inner canal. And yeah, that's pretty much it. After we come from the break, we will speak about the celiac trunk. Keep pushing. This is a high yield concept, really interesting one. Actually, this is highly clinically relevant, this one. We can speak about actual diseases. And yeah, the pectinate line for all of our dear proctologists. And after that, we'll speak about some liver structure, biliary structure, femoral region, and we keep pushing, and hopefully we finish until hernia today. So see you guys in 10 minutes. So yes, as we were speaking regarding the blood supply of our intestine. The celiac trunk is super important, and you need to be able to identify it on a CT scan. You should not identify the branches. You should know how to identify the celiac trunk itself. So, when you take a look here, you can see kidney, there is aorta, and there is a vessel coming out. Yeah? This vessel is giving branches. This is celiac trunk. End of the story. Don't confuse it more than that. So, anytime you see a vessel at the level of the liver, that's the celiac trunk, okay? If you see a vessel coming out from the aorta and you see the spleen and the liver all in the same picture, this is a celiac trunk, okay? Nice. So branches of the celiac trunk are as follows. We have the common hepatic, we have the splenic, and we have the left gastric. So this is the celiac trunk. You can see that it has the splenic, which goes posterior to the stomach, yeah? And also it has the common hepatic, which gives branches for the liver, but not only. Except the liver, it also gives branches to the stomach and the duodenum, okay? And finally, we have the left gastric, which include the smaller curvature of the stomach. Okay, before I move on, Just general anatomy, really quick. What do we call this portion of the stomach? Fundus. Okay. What do we call this portion of the stomach? Pylorus, antrum. What about this? No, this is not the body. This is the cardia. This is the body. Okay. So these constitute the main blood supply to the foregut. Foregut. Remember, foregut was all the way until the duodenum, the upper portion of the duodenum. We have strong anastomosis that exist between two areas. Why they mention strong? They are telling us it's strong. For us, it's a different way of telling us, well, this is not a watershed area, okay? Left and right gastroepibloic. So let's take a look at that. So we have here the right gastroepibloic, which came from the gastroduodenal, which came from the what? It came from the common hepaticus. And we have the left one, which is coming gastroepibloic. It's coming from the splenic, and the splenic coming from the celiac trunk. Basically, both of them are coming from the same structure, but from two different areas. Yeah? So, the next thing that you must know is the left and the right gastric. The left gastric, we just spoke about it. It comes directly from the celiac trunk. But the right gastric, you must know that it comes from the common hepaticus. There is a few more points I would like for you to know, guys. It's not a watershed area, yes. So, if you take a look here, you can see this vessel, which is the gastroduodenal. It's going posterior to the duodenum. Why I'm obsessing about it? Because if the patient will have a duodenal ulcer, and the duodenal ulcer is anterior, is he going to bleed much if it was anterior duodenal ulcer? No, he will not. So again, if this is the duodenal, let's just imagine that I made a section here. This is the duodenal. Behind the duodenum, we have this vessel. What is this vessel? The gastroduodenal. Anterior to it, there is nothing. So if the ulcer is in the anterior wall, you are going to have perforation, which will lead to air inside of your abdomen, which lead to something called, what it will lead to? Not double bubble, no. It will lead to something called subdiaphragmatic air, okay? Subdiaphragmatic air. Basically, you will have air directly under your diaphragm. Well, somebody will be like, okay, how can I differentiate it from the stomach blob? You will not have two stomach blob, okay? So, basically, and you don't have a stomach on the right side, yes? So you can see subdiaphragmatic air, which represent perforation. So subdiaphragmatic air is for perforation, and that's only in the anterior duodenum ulcer. If the ulcer was posterior, what symptoms I will have? Can somebody tell me which symptoms I might have if it was posterior? Bleeding, absolutely correct. Yes, bleeding is the main thing. Yes. Okay. So the next thing to appreciate here is, the next thing to appreciate here, if I'm going to have a gastric ulcer, is it more likely to have the ulcer on the greater curvature or in the smaller curvature? The ulcer is most likely to occur at the smaller curvature, okay? And the vessel that will be affected the most are the left gastric vessel, okay? The last thing I want you to know is about the esophageal branches, which can go up and create anastomosis with the esophagus. Okay, that's it. The next thing is about the portosystemic anastomosis. These are high yield. Why? Because they have so many, which one? The bleeding. Why bleeding? Are you asking why we have bleeding? So, oh, good question. So, what is the most common cause of ulcer? It's a bacteria. Which bacteria? H. pylori. H. pylori is the most common though. H what? Pylori. Why do we call it pylori? Because it's most likely affect the pylorus of the stomach. And actually, if you take a look where is the most common area to be affected, it will be like this, okay? This is the most likely area to be infected by the H. pylori, okay? So that's why it is more likely to get the ulcer there. Also, in the near future, I mean in a few pages, we'll be speaking about some cells in it in physiology. And I will be telling you that some cells will be located in the fundus of the stomach, some cells will be located at the cardia of the stomach, and some vessels are going to be located at the pylorus of the stomach, which are totally different actually. Okay, now we have a liver. To get portal hypertension, to get a portal systemic anastomosis problem, before we speak about any of that, I would like you to know, guys, why would we get liver problem? Can somebody tell me why would I get cirrhosis and portal hypertension? What are the causes? Alcohol, excellent. What else? Drug. What a drug? Viruses like hepatitis B, hepatitis C. Not the NSAIDs. Maybe you wanted to say paracetamol, like acetaminophen. He is hepatotoxic. What else? Yep. Okay, good. So also some renal disease that have many cysts. Was it autosomal dominant or autosomal recessive? Polycystic kidney disease. No, one of them have the cyst, one of them have the fibrosis. The autosomal recessive one have liver fibrosis. The autosomal dominant one has the liver cyst. This is a high yield. You need to know how to differentiate between the two. The gene defected in autosomal dominant polycystic kidney disease was polycystin. The gene defected in case of autosomal recessive disease was fibrinocysteine. These are different. You need to know how to differentiate between autosomal dominant and recessive polycystic kidney disease. One more question. Which one will have the late manifestation? The late manifestation are for autosomal dominant. The early manifestation are going to be for the autosomal recessive. The manifestation are super early, that they occur when the baby is still in the mommy uterus, which leads to what? Absolutely, oligohydramnios, which can lead to Potter sequence. Absolutely correct. Potter sequence can lead to pulmonary hypoplasia, the cause of death. Okay, so the liver is messed up. Now we will have a backflow of blood backward. I want you to know that we have two types of venous system in our body. We have the systemic venous system and we have the portal venous system. What is the portal vein? Well, the portal venous system is a system of blood that drain all of the blood from all over the intestine back to our liver. Okay, so you can see the blood coming back from all over the intestine back to our liver. So if the liver is messed up, we are going to have portal hypertension. Okay, we are going to develop portal hypertension. And when we speak about as you can see, all of these vessels are coming back here. But we also have one more system in our body, which is called the caval system. The caval system is totally different, and normally we should have minor connection and no major connection between the two. Okay, so we actually do neglect the connection because they are super small. But in some cases, this small connection will become high yield. Why? Because the flow becomes backward. Normally, the flow is like this. Let me do this. So the flow normally is like this. It's going to the liver. Yes, because they take all of the substances and they send it to the liver. In case of portal hypertension, the liver is messed up, so the hydrostatic pressure inside of the portal vein is going to increase, which increases the hydrostatic pressure inside of the other vessels, leading to portal hypertension. In case of portal hypertension, we will have activation of these anastomoses, which will lead to symptoms. Yes? So, what are these anastomoses? And they are between what, and which system we are going to have. This anastomosis, any anastomosis means a connection between two vessels. This is the definition of anastomosis. Excellent. So, it's a connection between the caval system, yes, and the portal system. The first connection is number one, they say, in the esophagus. So, in the esophagus, we are going to have what? We can have the connection between the left gastric, which came from the celiac, and the esophageal vessel, which comes from the azygos vein. When these are together, we are going to have esophageal varices. Is it dangerous, esophageal varices? I mean, yeah, there is like this esophageal varices, but can they kill us? Yep, 25% of all patients with liver cirrhosis die from this thing. See this thing? This is little varices inside of the esophagus that kill the patient because of dilatation of the vessel, because of the increased hydrostatic pressure inside of the portal vein. I just want to show you a bleeding of it because it's just like unforgettable. And yeah, just take a look at this. I just want to show you how serious this is. If you, yeah, take a look at it. See, it's bleeding. See how it's bleeding? So this is totally can kill you, but and there is a way to treat it, but see, it's majorly bleeding, and this major amount of bleeding can totally kill the patient. Yep. So we need to be really careful with it. We need to treat it as fast as possible. For example, here he's using the method of ligation. He's putting a band. He's banding it up. But this is not the only way to treat it. There is many ways to treat it. You can treat it by a balloon. And for the sake of that, I today made you a simple presentation. It will take just 5 minutes to tell you in general what you need to know from it, and how to manage such varices as doctors. So basically, it happens because of portal hypertension. Portal hypertension definition is when there is more than 10 millimeters of mercury of pressure. It can be due to multiple problems that we get portal hypertension, which can be due to, for example, a prehepatic cause, like for example, thrombosis of the splenic vein or portal vein. Also, it can be cirrhosis of the liver, schistosomiasis, remember about this one, or also it can be due to Budd-Chiari syndrome. Anyway, this is not the important thing. The important thing is here. So you can see here the connection between the azygos vein and the what? And the gastric vein. I am a newbie, so I don't know how to make the screen big. I think it's this. It's not. I really don't know how to do it. I hope. Oh, okay, it's like this. So, yes. So if we are speaking about the, this one, this is the connection is occurring here, which lead to the formation of this anastomosis and the variceal bleeding. So if it occurs here, for example, around the umbilicus, which is the para-umbilical vein, it can lead to something like this. See? What is this, guys? Somebody wrote it already. It is caput medusa. Yeah? Caput medusa. And you can see the acidic fluid inside of the abdomen, and you can see the caput medusa. Okay. You can see the variceal bleeding. Here is an image of them. Yeah? And you can see an X-ray with barium study. One of the ways to treat them is just to stick a big balloon inside and inflate it as much as possible, which is going to block the bleeding from bleeding anymore. Another way is like to inject ethanol into it, which will halt the bleeding and kill the vessels. The third way you saw in the video, which was the ligating. Yeah. So you put this scope. You have this band on it. You release the band over the varices, and that's it. The last one is tips. which is a transjugular intrahepatic portosystemic shunt, but this one is a little bit different. We'll speak about it in details now because it's high yield. So yeah, that was really quick about the esophageal bleeding and different ways of managing it. And now about the umbilicus, we will have caput medusa. You saw a picture about that. We'll have paraumbilical or a small epigastric vein of the anterior abdominal wall. Okay? So the rectal type of anastomosis can lead to anorectal varices, which can affect the superior rectal portion, also middle and inferior rectal. Okay? So when you have such thing, you are going to get a rectal hemorrhoid. Are these hemorrhoid internal or external? This is important. Internal hemorrhoid. So are they painful or painless? Painless. Okay, varices of the gut, butt, and caput, gut, butt, and caput are commonly seen in portal hypertension. So, guys, what is a medusa? After all of you guys are future doctors, so or already a doctor, some of you actually. So you need to know more about what these are. So absolutely, it's a mythology. Basically, it's an idea about a lady that having her hair made out of snakes. And yeah, it's the Greek stuff. Yeah? Oh yeah, that's the caput medusa. Absolutely. Okay, so and somebody looked at someone with this umbilical type of dilated veins, and he was like, it looks like a caput medusa, the head with a lot of snakes. The treatment is with a transjugular intrahepatic portosystemic shunt between the portal vein and the hepatic vein. This is high yield. Guys, it's called transjugular. So it connects the portal vein to which vein? We call it a transjugular, so it connects the portal vein into, come on, come on. This procedure is called the transjugular intrahepatic portosystemic shunt. So it connects the portal vein into the hepatic vein. Okay? This is important because the name means nothing like the actual procedure. It's a tricky question. They ask you what connect during tips, which vessels are you connecting? And people remember, okay, it was tips. What does tips it stands for? Transjugular intrahepatic portosystemic shunt. So it must be the jugular vein. Completely wrong. It's not the jugular vein. It is the hepatic vein. Look at this procedure. It's just connecting this to this. Okay, we are connecting this to this. We connected either to the hepatic vein. If this is not an option, choose IVC. Okay? Isn't it where they insert the catheter? I'm not sure what you mean by that. Yeah, but they ask about the shunt. Where is the shunt located? You know? They ask about where is the shunt located. And if you say that the shunt is located between the portal vein and the jugular vein, this is wrong. Yeah? It must be between the portal vein and the hepatic vein. If that's not an option, go with the IVC. Okay? Which is like the portal vein and the IVC. So, this is important. Do not fall to their tricks. You know better than that. But, guys, does anybody know where is the urea cycle located in our body? In the liver. So, it converts ammonia into urea. So, if I do such thing, what is going to happen to the ammonia coming from the intestine? Will it be metabolized by the urea cycle, or it's going directly to my inferior vena cava? You should say liver. Always trust your liver. It's urea cycle. Yes, it will go directly to the inferior vena cava. Okay? So it goes to the inferior vena cava, And is it all right to have ammonia in our circulation in a high amount? Absolutely not. Yes, we cannot have a high amount of ammonia, because if we have high amount of ammonia, ammonia will go where? Which organ? Not kidney. Because normally ammonia is converted to urea. Urea go to the kidney. Yeah? But now we are blocking this because no urea cycle. So the ammonia will go to the brain. What it will lead to in the brain? What problem is going to happen in the brain? Yeah, that's true. It's going to deposit in the basal ganglia, which can lead to something called oh my god, my dictation is failing me. Asterexis? Nah. Okay, I will show you in a moment. So asterexis, which is a shaky hand movement, okay? That's one thing. But this is not the only problem. The brain itself is going to become swallow up. And if they ask you why, it's because the ammonia convert into something called glutamine. Glutamine. Make a huge note about that. The glutamine suck water. The water lead to brain edema. Brain edema lead to hepatoencephalopathy. So hepatoencephalopathy due to the ammonia accumulating inside of the brain, which will be converted into glutamine, which will suck water, leading to brain edema and neurological symptoms, including asterexis. Okay, let's take a look what they write. They write, yes, which relieves tips relieve portal hypertension by shunting the blood to the systemic circulation and bypassing the liver. Tips can precipitate to hepatic encephalopathy due to decreased clearance of ammonia from the shunting. Shunting, ammonia cannot be converted to urea. More ammonia in the brain, more glutamine, swelling, neuropathy. Nice. Okay, my favorite topic, pectinate line. What is the other name of pectinate line? Actually, it's not the other name. It's like, this is the dentate line, guys. And this is the pectinate line. But for the sake of you can imagine it to be the same thing, because it's just an area, okay? It's just a topographical area. We call this the dentate line because it looks like teeth, guys, okay? So this is the pectinate line, or the dentate line, whatever you want to call it. Anything above it is the colon. Anything under it is the skin. So can somebody tell me which type of epithelium is going to be above the pectinate line? Columnar epithelium, absolutely. Which type of epithelium is going to be under squamous, stratified squamous? Absolutely. Yeah. Nice. So also called dentate line, pectinate line, also known as dentate line, formed where the endoderm, which is the hindgut, meet the ectoderm, which is the skin. Guys, if you still don't know what is endoderm, mesoderm, and ectoderm, it's totally okay. We'll study this in reproductive, but just for a quick overview, just want to give you like a few notes so you will not trip if somebody asks you. So endoderm is the GI and all epithelial cells, okay? Mainly the GI. Mesoderm include the spleen and the muscles and the blood, okay? Spleen, muscle, blood. Ectoderm is the skin and the brain. Skin and brain. So you are like, wait a second, is the skin and the brain coming from the same embryological origin? Yes. That's why neurological disease are highly associated with cutaneous problem. Have you ever heard about neurocutaneous disorder, neurofibromatosis, tuberous sclerosis, all of this stuff? It's because the CNS problems are highly associated with the skin problems, okay? So, you can see that the innervation of after the pectinate line can be somatic. It means that we feel it. And it comes from the pudendal nerve. So that's S2 until S4. Also, the blood supply comes from the inferior rectal artery. This is high yield. You need to know that it comes from the internal pudendal artery. Pudendal nerve, pudendal artery. Okay, so The inferior rectal vein go to inferior pudendal vein as well. Internal iliac, common iliac goes to the IVC. Finally, the drainage. This is high yield. I saw so many questions about this, guys. So many questions, you have no idea. That they ask you, where does the anal verge? This is the anal verge, okay? They ask you, where does the anal verge drain to? And the answer is superior inguinal lymph node. Okay. What about above the pectinate line? So if we speak about the nerves, it is visceral innervation. Can you feel it? The visceral innervation. Can you feel visceral innervation? Yes or no? No, you cannot. The arterial supply comes from the superior rectal artery, which is a branch of the IMA. The veins, again, superior rectal vein, IMV, and splenic vein and portal vein. You are like, why splenic is related? Well, take a look. When the blood comes from the rectum, it keeps coming up here. It attaches to the splenic, and the splenic takes it here. So if someone has a, if you get a weird case, this is super rare to be asked, but I'm just telling you for the sake of completeness. If someone has a thrombosis of his splenic vein, he's going to develop what? Hemorrhoid, but he will not develop caput medusa, and he will not develop esophageal varices, only hemorrhoid. Okay, the next one. The lymphatic, they drain to the internal iliac. So above the pectinate line, we have internal hemorrhoid and adenocarcinoma because it's a columnar type of cells. Internal hemorrhoid receives visceral innervation, and therefore they are not painful. We established that. Below the pectinate line, the external hemorrhoid exists, and oh yeah, this is important. Anal fissure. So this anal fissure, is it painful or painless, guys? It's painful. Let me tell you a little bit about anal fissure, because it's really common pathology that affect, how many people do you think get anal fissure during their life? Around 20 to 30% of the whole population. I mean, today, from today group, we are going to have at least 2-3 people who will get it. So, women mostly, but to be more exact, children mostly. Let me tell you why children. Here is the story. The story is about a child who goes to the school. The school bathrooms are dirty. Do you agree, guys? It's always dirty. I don't know why, but school bathrooms tend to like to be dirty. So the school bathrooms are dirty, or even could be not dirty, but anyway, the child is too shy to use the toilets in the school. So what will he do? He will not use the toilet. He will not use the toilet, and he will come back home. Because he did not use the toilet when he needed to, he's going to have what? Constipation. He came back home and did not use the toilet because he was distracted. The next day, he went to school. He did not use the toilet again. So now, what happens to the feces? I mean, what is the function of the colon? To suck water out of the feces, yeah? So when the feces stay in the colon for a longer period of time, are they going to become more soft or more hard? They are going to become more hard. So, one more day passed, third day passed, fourth day passed, the same story. Now he's going to poop. He's going to defecate, and when he defecates, he's going to injure himself because it's super, super hard. Okay, he injured himself. He have now an anal fissure. Next day, he wanted to use the bathroom. He went to use the bathroom. It's so painful. So he decided not to use the bathroom. Okay? So when he did not use the bathroom, he got constipation again. Yeah? He did not use the bathroom, so got constipation. Constipation, more stools for a longer period of time. What is going to happen to the stool? If it stays there for a long period of time, hard again. And he's too afraid to use the bathroom. Why? Because it's going to hurt. Yeah? So he does not use the bathroom. Eventually, sooner or later, you are going to use the bathroom. But this time, when you use the bathroom, it's really hard. So when it gets out, what it will do? Anal fissure again. So the anal fissure is going to become worse. And this is like a cycle, guys, as you can see. So this cycle is a vicious cycle that has no ending. The problem is that most of these children are too shy to tell their parents about it, okay? So you need to suspect it. I'm telling you, this is a case in the USMLE, yes, but you also need to suspect it in real life, especially if it was like a 7-8-year-old boy or girl. Try to, not to ask him about it directly, try to ask him about it indirectly. And I will explain for you how you can take a look at it and know that this patient have it or not. So now we will learn how to look at it and know, yeah, this patient has anal fissure, but that will take a while. So squamous cell carcinoma, why? Because it's outside of the skin, outside of the pectinate line. It's to the outside, which we have squamous cells, so we can have squamous cell carcinoma. What is the cause of squamous cell carcinoma? Come on. What causes squamous cell carcinoma? Of the cervix, of the head and neck, of the lung, of the cervix, of the penis, of the anus. HPV, human papillomavirus, absolutely correct. Yes. So external hemorrhoids receive somatic innervation, inferior rectal branch of pudendal nerve, and are therefore painful if thrombosed. So if you thrombose these vessels, it's going to be hella painful, and they are at the lower portion. Yes? So the anal fissure will lead to a tear in the anoderm, which is the skin of the anus, below the pectinate line, so that's painful, pain while pooping, blood on the toilet paper. This is important. It's located at the posterior midline because it's poorly perfused by blood vessels, okay? And it's associated with low fiber diet and constipation. You understood why constipation in the case of the boy, because he's disgusted of using the bathroom, and then he's afraid to poop because it's painful. Low fibers are these people who only eat hamburgers. And to speak about one more thing about anal fissures, I wanted to tell you one thing. Yes, how can you take a look at an anal fissure and be like, this is an anal fissure? So, okay, this is an obvious anal fissure, but most of them will not be like this. Most of them are going to be like this. What is that? This is an anal tag, we call it. When you have the patient with an anal tag, if you see that, that's it. You have a diagnosis. If you see an anal tag, that means this patient has an anal fissure. Again, let's take a look at an anal tag. This is an anal tag, okay? This portion. He's grabbing it, it's anal. Oh, yeah. Okay, this is an anal tag. Guys, by the way, is it painful? It's hella painful. Yes, it's supplied by somatic innervation. That makes it really painful. Okay, so also called sentinel bile, or also a tag. As you can see, it looks like this. Let me send you these pictures. Okay, so let's learn how to treat it. This poor patient is suffering from it. So how to break the cycle for the boy? Two things. The first thing, you will be like, listen, you need to apply this cream every day on your anus. It's basically, which cream are we giving him? We are giving him a calcium channel blocker cream, okay? So some of the Dibine family, okay? But it need to be a cream. So you give him a calcium channel blocker cream. I think, no, it need to be something with a cream. Nifedipine will do it. Amlodipine will do it. Yes, so you can give him amlodipine but it needs to be in a form of a cream. That's the main thing. So when we put that on his anus, topically, what is going to happen to his anus? Well, previously, because of the injury, he was too afraid to poop that his anus is so stretched. So now you put the calcium channel blocker and it will relax. So he will be able to poop much more easier. Also, you are right. You need to give him stool softeners. Yeah? Like you need to increase the fiber in his diet. Will it go away if you do that? Absolutely. It will go away and possibly it will never come again, except if he gets into the same cycle once again. Hopefully he will not. Okay, so let's take 10 minutes break and see you guys after the break. Hello everybody, welcome back. So let's continue this session. We are going to speak right now about the liver structure. So, okay, the liver. The liver is one of the most important organs in our body. What it does, let's see. It stores vitamin. It stores iron. It does secrete a lot of secretes a lot of stuff. Bile, urea cycle. Of course, it can do that. Maybe store vitamin. Yes, it does that. Vitamin A, absolutely. Vitamin D, does it participate in it? Yes, it stores it, the 25-hydroxyvitamin D. What else? Cytochrome B450? Sure. So you see so many things they can do. Okay, so the liver tissue architecture. The functional unit of the liver is made out from a hexagonal arranged lobules surrounding the central vein with portal triads on the edge. Let me explain. You remember maybe when we spoke about the portal vein. The portal vein inside of the liver start to make the sinusoid and eventually it reaches the central vein, which will keep going until it reaches the what? The hepatic vein. Okay? So if we speak about a patient that has portal hypertension, the destruction will be in the liver, okay? So that will lead to the portal hypertension. You need to understand the connection between these two, okay? If we speak about the other thing, which is basically, what are these two other structures? Well, the bile is made up inside of the liver cells, inside of the hepatocytes, and it keeps moving until it can exit from the liver. Okay? So, the next thing is, yes, the next thing is the hepatic artery. The hepatic artery delivers the blood into the liver, yes? And it goes also through this hepatic triad. So, the hepatic triad is like this. Okay? So it has this portal vein, bile ductules, and hepatic artery. 3 structures, not one. So after that, we have formation of the hepatic triad, and the blood from it is going to pass this way until it reaches the central vein. After the central vein is going to go where? Into the hepatic vein. But the bile goes vice versa. The bile comes from here, go to the bile ductules, keep going down until it reaches the biliary system. So that's in general, what does it mean? Central vein and hepatic triad. So this is the hepatic triad, hepatic triad, hepatic triad. We have a hexa of them, which is 6. Okay? The next thing is going to be as follows. Apical surface of the hepatocyte faces the bile caniculi, and the basolateral one faces the sinusoid, which means something like this. So this is the apical side of the hepatocyte, and it faces the what? The ductules, which makes what inside of them? The bile. Okay, and their basolateral side, which is the other side, it's going to face the sinusoid, which have passage of what? The answer is blood. So, Kupffer cells. Each organ in our body has a specialized macrophage for it. For example, If we speak about the liver, it's the Kupffer cells. If we speak about the brain, it's the microglial cells. If we speak about the skin, it's the Langerhans cells. If we speak about the lung, it's the dust cells. So each organ has its own macrophage. It's located in the sinusoid. They say it's the black arrow. Where is the black arrow? Black arrow. Here it is. Okay. So it is this thing. It looks like it's full with the trash, as you can see. It's the only one that is not red. Okay. So yellow arrow is the central vein, which is this one, and this is the triad. Yeah? You can see the vein, the artery, and the bile ductules. The one trick to differentiate a vein from an artery, a vein is always much larger because it has more blood in it, yeah? Remember, the storage of the blood always happens at the vein, not at the artery. Also, the artery has an internal and external elastic lamina, which makes it more compressed, yeah? While a vein does not have an internal and external elastic lamina. So, the function of the Kupffer cells is to clear the bacteria out and damaged damaged RBC. For example, if we have an RBC that is damaged, we need to clear it out. We say we clear it out at the reticuloendothelial system. What does that mean? Reticuloendothelial system is a fancy word of saying macrophages, which are located in the spleen and in the liver. Okay? Reticuloendothelial system. So the next thing goes something like this. We have a hepatic stellate, also known as the ethos cells. They are located at the space of Dissy. You are like, wait, space of what? Space of Dissy. So this is the space of Dissy. Okay? So we have the sinusoid here. It has the Kupffer cells in it. And we have the space of Dissy. This space of Dissy contains this guy, which is the stellate cells. And this stellate cells, also known as ethos cells. The ethos cells are really important because they store vitamin D and vitamin A, and they do ask about this. And they also can help us to produce the extracellular matrix, which can lead to fibrosis. Okay, so it's responsible for hepatic fibrosis. If they ask you what is the mediator of fibrosis, what you will write? What is the cytokine that is the mediator for fibrosis in the liver? Come on, nobody know what is the mediator of fibrosis in the liver? Well, no. It starts with a T. Tumor. TGF-beta. Yes, absolutely. TGF-beta. Okay? TGF-beta. So the TGF-beta is the one that is responsible for the hepatic fibrosis. Guys, lung fibrosis, hepatic fibrosis, whatever fibrosis, it's always TGF-beta. Okay? So inside of the liver, we have 3 zones. So we have the zone 1, zone 2, zone 3. Each zone has a story, and each zone has a function, and each zone has a level of O2 supply. So let's take a look. If we speak about the oxygenated blood, you tell me, guys, is it more at the triad or at the central vein? The oxygenated blood. At the triad, because it has an artery in it. Absolutely. So which area is going to suffer from hypoxia the most? Is it area 1, 2, or 3? 3, absolutely, yes. So they also write for us, okay, let's say somebody got some viral hepatitis. So first of all, it came from here. The first area to be affected will be area number 1. So area number 1 is the most likely to be affected by viral hepatitis. Okay. And it's the best oxygenated. That means it's the most resistant for circulatory compromise. So if you get a statin shock, area number 3 will not be affected. If you ingest toxins, but be careful, it's not the drugs, it's actual toxins. If you ingest toxins, they will come from your portal vein, come here and destroy this guy. Guys, do you remember a toxin that inhibits the RNA polymerase that can lead to hepatotoxicity because it gets absorbed? from the intestine and goes to the liver? What was it? A toxin that inhibits the RNA polymerase. Toxin that inhibits the RNA polymerase, that after we ingest it, it goes to our intestine, destroy the intestine, and then it goes to the liver, destroying the liver, especially zone 1, because it's the first area to hit it. Absolutely correct. It's the death cap mushroom leading to the afla-amantine toxin, which destroyed the zone number 1, because it's the first area to be affected. Zone number 2 is the intermittent zone, and it's affected by yellow fever. Which country has the most cases of yellow fever? Or which region? Well, it's mostly African countries, yes. Guys, to be totally truthful with you, yellow fever is not that much in Egypt, but for the USMLE, they give you a patient from Egypt. So just keep that in mind. I mean, if you get a real patient from Egypt, do not highly suspect that. But if you see it in the USMLE, this is an alarm, okay? What is the only European country that has yellow fever? The only European country that has fever, it must be France, but I cannot find it in the picture. It should be France. It should be France, guys. So yellow fever can be in France as well, but I cannot find it in the picture. Anyway, so absolutely the immigrants. So there is, oh yeah, wait a second. So yeah, it's France. Can you see it? A lot of people in France have yellow fever. Absolutely, from the immigrants. Here you go. Okay, does anybody remember which bug or which mosquito transmit the yellow fever? Yeah, that was me. Thank you. Yes, the Aedes mosquito. Yep. So the zone 3 is the very central. It's just around the central vein. It affected. It's the most distal area. So, is the most distal area. Will it have a lot of oxygen here? I mean the vessels with the sinusoid. Will the sinusoid have a lot of O2 here at the zone 3? No, they will not. So if I get in a state of shock, the area that is the most susceptible to the injury is going to be zone 3. Absolutely. So zone 3 is the very central, also called central lobular zone, affected first by ischemia because it has the least oxygenation, high concentration of the cytochrome B450, the most sensitive to metabolic toxin like ethanol, like vodka, and tetrahydrochloride. This one is important. Tetrahydrochloride. You are like, never heard of that. Well, you know, guys, what is a dry cleaning? Yeah, yes, excellent. So there is this people who do dry cleaning. Oh, there is one near my house. Anyway, these people who work in the dry clean industry, they use some special, like something to clean the clothes that contains tetrahydrochloride. I mean, for us, it does not matter a lot, even if you use it sometimes, because we don't use it every single day. But people who do the dry cleaning do participate in this every single day, which lead them to become high risk of developing this type of cancer. Basically, not cancer yet. The tetrahydrochloride becomes a free radical. That free radical can damage this portion of the liver. After that, it can lead to mutation, and it can precipitate into hepatocellular carcinoma. The next thing is halotone. Halotone is a general anesthetic. This general anesthetic, we will learn about it, but what I want you to know is that it's used less in the US. I'm not saying that it's not used, but it's used less in the US because of the hepatotoxicity. So if you have a patient who gets into a surgery and after that he gets a really bad LFTs, liver function test, think halotone. Rifampin. Does anybody remember, does it induce or inhibit the cytochrome B450? Induce, it ramps up the cytochrome B450. And acetaminophen, somebody said about that today, this is also hepatotoxic and affect the zone 3. And the zone 3 is the site for an alcoholic hepatitis. Good. Let's keep going. I just want your permission really quick to keep going. I would like just to finish a couple of more pages, so I want your permission. Let me write this. Come on. Nice. One more, please, so we can go. Okay, I think it's good enough. Okay, done. So now let's speak about biliary structure. First of all, let's try to think, how does the biliary system goes? So the biliary system start as follow. Biliary tract. So the biliary tract goes something like this. We have a left and a right hepatic duct. They join together, make common hepatic duct, which connect to the cystic duct and make the common bile duct. The common bile duct connect with the pancreatic duct, and they open up into something called the ampulla of Vatar, which is this dilated area. Okay, this is the ampulla of Vatar, the dilated area, and they finish up with the sphincter of Oddi. So when we speak about this structure, we need to appreciate a few areas. What is the difference between them? Where the ducts open? And what will happen if we have obstruction of different portions? So they write here, cholangiography show filling defect in the gallbladder. And yeah, can you see the gallbladder here, guys? Can you see it? Can you see the gallbladder here? Can you see the gallbladder, guys? Absolutely correct. You cannot. If somebody told me that you can see the gallbladder, that would be a lie. You cannot see it. It's not filling. Why it's not filling? It's not filling because there is some form of obstruction. So if I draw the gallbladder like this, wow, nice, green. So it goes something like this. We have the left and the right hepatic ductule. This is the common hepatic duct. Yeah, common hepatic duct, which keeps going. This is the cystic duct here. This is the common bile duct, which is also called cholidicus, and it attaches to the pancreatic duct, which continues like this, makes something called the ampulla of Vatar, which is a dilatation, and then ends up to make the sphincter of Oddi, that is going to open inside of the duodenum at the papilla minor. Not papilla major, but papilla minor. Okay, so if we say that we have a stone, and the stone is obstructing this region, yes? And we do a procedure called ERCP. You need to know what is ERCP. ERCP stands for endoscopic retrograde cholangiopancreatography. Let me explain what that is. We bring the patient, we put a scope inside of his mouth, an endoscopy. It goes all the way until it reaches the what? Until it reaches the duodenum. At the duodenum, what do we do next? Nice. We go through the papilla minor, and from okay, so let's take a quick look here. We are going through the mouth. Let's go deeper. Okay, we are going deep, deep, deep. Keep going. Okay, so notice what happens here. He went all the way until he reached the duodenum, I guess. Let's see. Yes. So he's at the duodenum. He entered the papilla. And then now he's going to inject a contrast. Take a look. So it's going to give color, 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 color. This is the common bile duct. It's giving color. Come on, more. Yes, you can see the right and the left branches now. Oh yeah, see how beautiful it looks. So basically it's really actually invasive procedure. You have to go all the way to the duodenum, and from the duodenum, do what? After you reach the duodenum, see, you go to the papilla minor, you go inside, you put this little wire in it. If you have a stone, you can take it out. How to take it out? You can take the wire, then inflate a balloon and take it out. This is one way to do it. So, see, the balloon, get it out. Done. We got rid of the stone. This is one way, but this procedure can be, you can use it to make a stent as well, but this procedure can be really dangerous, guys. Why do you think this procedure can be super dangerous? What is the most sensitive organ between all of the organs in front of us here? Anybody know what is the most sensitive organ here? The answer, it's not the stomach, it's the pancreas. If you touch the pancreas in a weird way and you lead to any type of obstruction, the trypsin will be activated inside of the pancreas, leading to pancreatitis, which can kill us. Yeah? So you need to be careful about that. Okay, and cystic duct. So gallstone that reaches the confluence of the common bile duct and the pancreatic duct at the ambula ovatar can block both the common bile duct and the common bile duct and the common pancreatic duct, causing both cholangitis and pancreatitis respectively. Basically, they are telling us if there will be a stone here, there are going to be a backflow to this side and to this side, leading to pancreatitis and cholangitis. Both of them. You get 2 for 1. Christmas gift. So the tumor that arises from the head of the pancreas, usually a ductal adenocarcinoma, can obstruct the common bile duct. This is important. Enlarged gallbladder with a painless jaundice, Corvusay sign. Why it's painless? This is super high yield. Guys, do cancer grow quickly or slowly? Super slow. When the cancer is growing slowly and he's obstructing this duct, the accumulation of the bile inside of the gallbladder is going to happen slowly. So the gallbladder is going to accommodate to the increased amount of bile, and it's going to dilate and become bigger and bigger and bigger and bigger and bigger until it becomes like a sack, okay? And when it becomes so big, it can lead to basically become palpable. I mean, you can feel it with your hand. And the patient will have jaundice. They will never tell you Corvusay sign. They just won't tell you that, okay? But what will they tell you? That a palpable gallbladder or a palpable big mass in the right upper quadrant and the patient has jaundice. This is Corvusay sign. Guys, the gallbladder will be really big. I mean, see, this guy, this is his gallbladder. This is ridiculously big, okay? You can see it also here. It's almost like as big as one lobe of the liver. That's how big it can become. So you can see, you can totally palpate that. So a palpable gallbladder with that size is highly suspected of pancreatic cancer. Pancreatic cancer is no fun. It's a death sentence. So, okay, we have the sphincter of Oddi. Remember its sensitivity to multiple drugs like opioid, which can also precipitate to pancreatitis. The next thing we are going to speak about is femoral region. We have, yes. So this is the femoral region. Keep in mind that we have this inguinal ligament. Under it is the femoral region, yes? So the organization, lateral to medial, we have the following. We have navel. I hope you know what is navel. It's like umbilicus. So you go from lateral to medial to find the navel. So we have nerve, artery, vein, and lymphatics. That's the navel. Nerve, artery, vein, and lymphatic. So femoral triangle contain the nerve, artery, and vein. So you are like, wait a second. What is this triangle? Well, the area under the transversalis fascia was subdivided into the following: a femoral triangle and a femoral sheath. So the femoral triangle contains all of these three guys. So the three most lateral structure, okay? But the femoral sheath, this one, it's a fascial tube. It's just a tube below the inguinal ligament that have vein artery, the femoral vein and the femoral artery, okay? And also contains the deep inguinal lymph nodes, but it does not contain the nerve. So it's really important to know that the triangle have the nerve, the sheath does not have the nerve. So triangle have nerve, sheath no nerve, okay? So the inguinal canal, this is important. See this picture, guys? It's kind of not that good, so but I'm going to explain it, then give you my picture. So the idea here as follows. We have inferior epigastric vessels. If the hernia was to the medially located to it, which type of hernia do we call it if it was medial to this one? If the hernia was medial to it, we call it direct hernia. If it was lateral to it, we call it indirect hernia, because it has to go inside of the inguinal canal. So when you look here, it's kind of confusing to understand the structure. So what I'm going to do, I'm going to draw something for you guys. And I hope like some of you will draw it with me because it's really helpful. This is the posterior wall of the inguinal canal. And this is the anterior wall of the inguinal canal. Actually, I should make it with no color, just like this. This is the anterior wall of the inguinal canal. So, as you can see, it's just like a, yeah, this is structure. And it has two holes. So, the first opening that it has, it is in the posterior wall, okay? And the next hole it has, it's in the anterior wall. So, posterior wall, anterior wall type of structures, and it goes something like this. So, I hope you can imagine it. There is a posterior opening, there is an anterior opening, and there will be a mass that will, there will be a spermatic cord that goes through it, okay? So the spermatic cord goes through it. Oops. Ah, damn it. Well, let me redo that. Just mistakenly got deleted. Okay, really quick. Posterior wall, anterior wall. Okay, so as you saw, we have multiple walls. We have the anterior and posterior wall. If the hernia occurs from the posterior wall and directly go to the anterior wall, we call it direct hernia, okay? So if it just like it go directly from the posterior wall, damage it, go to the anterior wall and go through the hole, we call it direct hernia. But if the hernia go through the deep foramen, then walking through the inguinal canal and go out of the canal, we call it indirect hernia. Okay, so how can I differentiate between the two? Well, there are some vessels that can help you with that. A few vessels are located here. We call them, yep, they are exactly right here. These are the vessels, the inferior epigastric vessels. So according to this, you can decide is it direct or indirect hernia. This is annoying, but you need to know the spermatic cord layers and where does each layer come from. Basically, the spermatic cord has this IST. So, ICE, internal spermatic fascia, cremasteric muscle, and external spermatic fascia. The thigh is going to be the following: transversalis, internal oblique, and external oblique. So these are just the names of the vessels. Okay, so that will be it for inguinal canal. We'll be speaking more about it regarding the hernias themselves. So let me just give you the last point here about the abdominal wall, and we will be done today with a good 8 pages, which is much more than I wanted to do. So that's good. Abdominal wall. So when we speak about the abdominal wall, we can see here the inguinal ligament, and we have here the vessels we spoke about, the inferior epigastric vessels. If the hernia was medial to them, we call it direct. If it was lateral to them, we call it indirect. Yes? So keep in mind one thing. If we are speaking about the medial portion, which is this one, it has another name. Anybody know what is the other name? Well, the other name is Hasselbach. Hasselbach. Okay? So we call it Hasselbach. Okay. Done. So the next thing is, we have here the femoral vessels, which are located within the femoral triangle. When you look at this picture, it's a little bit confusing, but try to dissect it. Just take a look at this ligament at once. So this is the what? This is the inguinal ligament. So under it, there is the vessels, yeah, the femoral vessels. Guys, do you remember these vessels I kept telling you about? I mean, these ones? Where do they come from? Well, let's take a look. This is the external iliac, yeah, which give the femoral. But the external iliac is going to give some branches backward. So if they tell you about a vessel that comes from from under the inguinal ligament and then give a branch backward, they are speaking about the inferior epigastric vessel. Basically, you can feel its pulsation if you search for it. And if the hernia is medial to it, this is direct hernia. If it's lateral to it, it's indirect hernia. And that's pretty much it. Okay, for the other notes, we will keep doing that for tomorrow. But for today, I think this is enough. And I will see you guys tomorrow. Thank you so much. And see you tomorrow, guys.